want to introduce our speakers for today. We have a very well established panel of experts on our topic today, which is hyperlipidemia. Amy Pierce is a cardiology nurse practitioner with Norton Heart Specialist. She received her nursing degree from Bellarmine University and her graduate degree from Spalding University. She is a board certified family nurse practitioner. In addition, she is a board certified lipidologist, and she runs the lipid clinic for Norton Heart Specialists. And she has been with Norton since 2011. Jacqueline Gray is also a cardiology nurse practitioner with Norton Heart Specialists. She received her nursing and her graduate degrees from University of Louisville. Jackie also has a postmaster's adult gerontology acute nurse practitioner certificate from the University of Kentucky, and she has been with Norton for 13 years. And finally, we have Kimber Woodrum. She is an employee population health and benefits clinical specialist at Norton Healthcare. She received her Doctor of Pharmacy from the University of Kentucky, where she also completed her Master of Public Health. She has completed her postgraduate year 1 and 2 in ambulatory care at Norton Healthcare. Finally, myself, Tara Mudd, as a planner for this, has the following relationship to disclose. I'm a consultant for AtriCure. No other planners or speakers have relevant relationships to disclose, and all relationships have been successfully mitigated. So with that, I'm going to turn it over to our speakers for our CME event for the day.
Hi, Sarah. Thanks for the introduction. Again, my name is Jacqueline Gray. I'm a cardiology nurse practitioner, and we'll go ahead and get into it. So we are going to be discussing the diagnosis, management, and treatment of dyslipidemia. Amy Pierce, who runs our lipid clinic, also contributed content to the non-pharmacology portion of this. And then Kimber Woodrum will be presenting the pharmacology portion. So the objectives, we would like to provide a brief history of dyslipidemia, to define and classify common types of dyslipidemia, and to review assessment and screening, explore prevalence, identify causes, risk factors, and complications of dyslipidemia, and then to discuss optimal treatment and management, review medication classes available for lipid management, and to identify appropriate therapy based on specific factors and conditions. So we'll start with a brief history. In the 1850s, Virchow discovered the association between atherosclerosis and lipids. And then about 50 years later, the term atherosclerosis was used to describe arterial obstructive disease. Shortly after that, there was a study that found that in rabbits, atherosclerosis could be induced by feeding them a diet high in cholesterol. Several years later, this was expanded upon with multiple studies. And then you can see in the 70s, normal cholesterol total cholesterol was 280 to 300. And then in the 80s, this goal began to lower to 240. In the 90s, statin treatment became the focus of clinical practice in order to lower LDL specifically. And then in the mid-2000s, target LDL goals were linked to risk, and then non-HDL was also used as a treatment target. So why dyslipidemia? Why even look at this condition? Well, heart disease is the leading cause of death. Over 18 million adults have coronary artery disease, which is the most common type of heart disease. Stroke is the 5th leading cause of death. And as we just discussed, hypertension, high LDL cholesterol, and high total cholesterol are major risk factors that lead to heart disease and stroke. Also, cholesterol has no symptoms, so many people do not even realize that they have high cholesterol levels. Give me just a minute. Okay. So let's get into some definitions. Hyperlipidemia is an abnormally high concentration of fats or lipids in the blood. the liver creates cholesterol to help digest food and create hormones. And then extra cholesterol can also be consumed in foods. Dyslipidemia is the term that you'll see used throughout this presentation for the most part, because it's all encompassing and typically an exchangeable term with hyperlipidemia. There's Lp(a), which is a type of LDL that carries cholesterol to cells in the arteries. And in general, the higher the Lp(a), the higher the risk for CAD. And we'll get into that a little bit later. So this is an image of a lipid particle to review. Their chylomicrons and remnants are referring to triglycerides in the core. And then we have 4 classes of lipoproteins and basically how they can apply to a basic lipid panel. So the VLDL carries the most triglycerides and is a predominant contributor to plaque buildup. This could be seen, if we did like a very specialized study that looks at it on an atomic level, but it requires special testing and a specialty lab. The intermediate density lipoproteins are byproducts of triglycerides, and we are probably most familiar with LDL and HDL. So LDL has been coined bad cholesterol because it carries lipids to the tissue. And HDL has been coined good cholesterol because it helps to remove cholesterol from the tissues to the liver, where it is then filtered out of the body. So prevalence in the US, this was looked at between 2015 and 2018, and over 12% of adults over 20 had total cholesterol higher than 240. So this is over 28 million adults. Nearly 94 million US adults over 20 had total cholesterol over 200. So, you know, these are big numbers. About 17% had low HDL or good cholesterol levels, less than 40. And slightly more than half of US adults who could benefit from cholesterol medications are currently taking it. So there's certainly room to improve on that. The prevalence of high total cholesterol. So this is looking at adults over 20. And as you can see in the kind of brighter green, it's the highest in middle-aged adults from 40 to 59. And then over 60, this number decreases in men, but it stays elevated in women. Prevalence of low HDL in the US. So this is the highest among men throughout the lifespan. Demographics, around 38% of adults have cholesterol over 200, almost 12% of adults have high cholesterol over 240. The mean serum total cholesterol for adults is 191. And interestingly, 7% of children and adolescents have high total cholesterol greater than or equal to 200. Approximately 2/3 of US adults report having had their cholesterol checked within the past 5 years. And women have a slightly increased percentage of high total cholesterol of over 240 compared to men. So demographics with race and ethnicity. This is looking at high total cholesterol over 240. And this was the highest in non-Hispanic white females and then non-Hispanic Asian males. But the numbers are pretty close together. There's not these huge differences that we see here. But in the US, Black Americans have 30% higher risk of death resulting from heart disease. And specifically, Black women have the highest risk of dying from heart disease compared with any other racial, ethnic, or gender populations. So there is racial disparity. This can be related to unequal access to care, cultural differences towards medical treatment. Several studies that we looked at actually suggested that medical conditions like hyperlipidemia may be underreported among minorities. And then Black and Hispanic populations in the US are less likely to have their cholesterol checked compared to the white population. And this is looking at the prevalence of low HDL or good cholesterol among race. So again, this is the highest in men throughout the lifespan. And you can see that this among men, this was the highest in Hispanic men and then non-Hispanic white men. So for assessment, it's always important to do, a good physical exam. So checking for deposits around the eyes and hands to check for xanthelasma. If their LDL is extremely elevated, like over 200, you would want to check around the ankles for deposits. And then looking around the eye for the halo to check for corneal arcus. And there's some pictures a little bit later on of the xanthelasmas. Taking a good patient history, family history, if the family has a high, if they have family history of dyslipidemia, then we may want to start screening earlier. Laboratory testing and ASCVD risk score, which we'll get into right now. So screening, the CDC recommendations included screening every 5 years for people over 20 who are at low risk, and then more frequently for people with CVD risk factors. So 1 in 5 adolescents has dyslipidemia. So it is important to get a baseline, which will typically be done and deferred to the pediatricians. But it's a good idea to check early so that we can start non-pharmacologic intervention with, diet and exercise recommendations. The United States Preventative Services Task Force recommended starting to screen men at age 20 to 35 if they're at increased risk, and for women age 35 to 45. So typically treatment with medication like a statin is going to be deferred to post-puberty or after women are past childbearing age, since statins are category X and contraindicated. But in patients who have known CVD or diabetes, lipids are typically checked at least every 6 months. So the standard lab is a fasting lipid panel. Additional testing to consider would be a CMP to monitor renal function and liver function, and then also a TSH. And the Lp(a) lab is typically an add-on. So if patients have, moderately good control, if we have moderately good control of their lipids, but we're kind of questioning whether we should push therapy further, the Lp(a) is a good indicator. And again, the higher the number, the higher the risk. Here's a very basic guideline of cholesterol levels. So if the goal would be total cholesterol under 200, goal LDL less than 100, and a goal HDL of 60 and higher. At risk when total cholesterol is between 200 to 239, or LDL is from 100 to 159. And HDL for men, 40 to 59, and for women, 50 to 59. And then dangerous or really concerning ranges are when total cholesterol is over 240, LDL is over 160, or HDL is under 40 in men or under 50 in women. So if the patient has, high risk, then the LDL goal would be less than 100. But if a patient has known CAD, peripheral vascular disease, or diabetes, the target LDL or bad cholesterol is typically less than 70. And an interesting fact is that, a newborn's LDL is around 30 to 70. A lot of times patients will ask, what is the lowest cholesterol? So we are born with an LDL, I guess around 50 on average. So the INTERHEART study, this looked at causes of heart attacks across 52 countries. And it indicated that dyslipidemia was responsible for over 50% of population attributable vascular risk. So over 90% of men and 94% of women, the risk of atherosclerotic disease was attributed to these 9 risk factors. So, smoking, elevated blood pressure, blood sugar, abdominal obesity, these APO and APOA are components of HDL and LDL, diet, physical activity, and then alcohol intake. The Framingham Heart Study is an ongoing study that was based in Framingham, Massachusetts. It's been going on for 74 years and across 3 generations. But it really kind of set up the framework for the ASCVD risk calculator and, you know, looked at the effects of HDL, LDL, triglycerides on heart disease. And it also looked at Lp(a) as risk factors, and then the cumulative effects of smoking and increased cholesterol on heart disease. So this is the ASCVD risk calculator. This is from the ACC website. And this was discussed some in the hypertension presentation, but I think it's important to reiterate because it, you know, it looks at age, sex, race, systolic and diastolic blood pressure, total cholesterol, HDL, LDL, if patient has a history of diabetes, if they're current or have ever been a smoker, if they're on treatment for hypertension, if they're on a statin, and if they're on an aspirin. And it develops a 10-year risk score for cardiovascular events such as stroke or heart attack. And you can see here, it's categorized into low risk, borderline risk, intermediate, and high risk. And once again, there's a dot phrase, an epic.risk that will populate the score if the appropriate labs, including a fasting lipid panel, vitals, are available and the patient is within the appropriate age. So this is Fredrickson's classification of hyperlipidemia. This is kind of a nice chart if you have questions, and we're going to get into each phenotype here a little bit more. But as you can see, type 2B and type 4 are the most common that we'll see in practice. Some of these are zebras, and we'll go over that. But if there's any questions, you can always refer to cardiology and we'll get them in with the lipid clinic. So type 1, hyperchylomicronemia. This is when triglycerides are through the roof. So triglycerides are over 1,000, and then the total cholesterol is only 1/10 of the triglycerides. So if someone's triglycerides are 1,000, their total cholesterol is only going to be 100. And this is often seen in children. You may see these eruptive xanthomas, these are pictures of that. And then, or it may present with recurrent pancreatitis, but pretty low frequency, 1 in a million. Type 2A, familial hyperlipidemia. So this is when total cholesterol is around 200 to 400 and triglycerides are normal. This may present with early CAD, tendon xanthomas, the corneal arcus, and the heterozygous is much more common. You may actually see this in clinic, and they should be referred to cardiology for high risk for a cardiovascular event. The homozygous is 1 in a million, but it's important to get these patients in early. Type 2B is the familial combined hypercholesterolemia. So total cholesterol 2 to 400, trigs are going to be 150 to 500, and then HDL is usually low. So this may present as premature CAD that's disproportionate to the degree of hyperlipidemia, commonly seen with metabolic syndrome. You will not see xanthomas with this, but this is 1 in 200 of the general population, and about 40% of the patients that are seen in the lipid clinic have this type of dyslipidemia. Type 3 is dys-beta lipoproteinemia. So total cholesterol of 300, trigs are around 300. This is when the total cholesterol and the triglycerides are actually equal. It's extremely rare, but something that you may notice on clinical presentation would be orange palmar xanthomas. So if you see a patient that has equal total cholesterol and triglycerides with orange palms and xanthomas, they need to be referred to cardiology. Type 4 is familial hypertriglyceridemia. So this is total cholesterol around 250, and then triglycerides are high, 400 to 1,000. This is seen pretty often in the lipid clinic, about 40% of the time. And then there's usually it can be associated with a high carbohydrate diet, alcohol use, and there's usually a family history of high triglycerides as well. So type 5 is familial lipoprotein lipase deficiency. So this will be total cholesterol of 250 and then really high triglycerides over 1,000. So this is something that's rare, and it often presents in adulthood in patients that have diabetes. So since Fredrickson, since those classifications, additional lipid diseases would be high Lp(a). And aside from the Lp(a), all of these other issues are inherited and would be diagnosed with genetic testing, which I think will become more important and more seen over the next few years. Risk factors for dyslipidemia. So it's all of the usual suspects. So obesity, family history, diet high in saturated fats, a sedentary lifestyle that leads to weight gain and obesity, smoking damages the blood vessels, the risk for high cholesterol goes up with age, and then gender. So until around 55, women tend to have a lower LDL than men, and then after menopause, this goes up. And then once again, men tend to have lower HDL throughout the lifespan. Diseases that can raise LDL. So if LDL is over 160, then a TSH should be checked because it could be due to hypothyroidism. So would recommend to treat the underlying condition before treating LDL. And then once that condition has been treated, repeating a fasting lipid to see where the LDL is at. So renal disease, obstructive liver, anorexia, HIV by itself, and it can be exacerbated by the antiretrovirals. They can both cause the increase in LDL. Cushing's, PCOS, pregnancy can all cause elevated LDL. But the bottom line is to make sure that the underlying condition is treated. So medications that raise LDL, so anabolic steroids that are used for bodybuilding. Typically, steroids that are used therapeutically don't increase LDL. Cyclosporins in transplant patients, progestin, thiazides, fibrates, and omega-3 can typically used to treat. Both of those are typically used to treat high triglycerides, but can also raise LDL some. Conditions that can lower LDL, surprisingly, acute coronary syndrome. So if a patient has an MI, their LDL can actually fall within the first 24 hours, and then it won't return to baseline for 4 to 6 weeks. So it's just something to keep in the back of your mind when you're seeing hospital follow-ups after an MI, that those labs that were drawn in the hospital may not be an accurate representation of where their lipids actually are. So it should be repeated after about 6 weeks. Conditions that lower HDL, insulin resistance, smoking, increased diet high in carbohydrates, very low fat diets, a diet high in trans fats, inactivity, anabolic steroids. And by quitting smoking, it can actually raise the HDL by 20% in 8 weeks. So that's pretty significant. Most low HDL is not inherited. Medications that lower HDL, so beta blockers, isoretinoids that are used to treat acne, adding glitazone to a fibrate, progesterone, and again, anabolic steroids. When this is used to treat, like testosterone is used to treat hypogonadism, there's not typically significant decreases in HDL that are seen. This is more with bodybuilders. Medications and conditions that increase HDL, so aerobic exercise can increase HDL, and then alcohol and estrogen. But we don't recommend for patients to drink more alcohol above the guidelines based on this. Conditions that raise triglycerides. So hyperthyroidism, poorly controlled diabetes, type 1 and type 2 diabetes, anorexia, HIV, hepatitis, chronic renal disease. These can all raise triglycerides. And then these medications can all raise triglycerides. So, estrogen, oral contraceptives, SERMs, beta blockers, retinoids, steroids, but we would not recommend holding treatment for underlying issues due to increased triglycerides, but it's just good to have an awareness if you see kind of a sudden spike after starting any of these. So, the risk for untreated dyslipidemia runs high. It's stroke, it's heart attack, it's sudden cardiac arrest, microvascular disease. So that's why it's important to identify this and treat it early, especially because most of the time patients don't have symptoms. Non-pharmacological treatments, diet is one of the mainstays. So a healthy heart diet, low saturated fats, lower carb and sugar. And then saturated fats are meat, butter, cheeses, full fat dairy. And this has been studied just by decreasing the intake of saturated fats to less than 7% of total calorie intake. It can decrease LDL by up to 10%. And then sterols and stanols, these are substances found in plaque that block the absorption of cholesterol. And adding 2 grams of sterols can lower LDL by roughly 10%. These are found in vegetables, fruits, nuts, seeds, and some cooking oils and butters are actually enriched with sterol. Soluble fiber can decrease, having an adequate intake of fiber can reduce cholesterol and decrease LDL. So Metamucil, oatmeal, Cheerios, they can all, having adequate intake can lower LDL by roughly 10 points. And then omega-3 fish, ocean fish twice a week can also help to ensure adequate intake of omega-3 fats. And then weight loss, losing 5 to 10% of body weight can also improve cholesterol. Typically, in clinic, we will give patients around 3 months to start to show improvement with lifestyle modifications. And then after that, if the lipids are still elevated, we might press more on medical therapy. And then non-pharmacological treatments also includes exercise. So this has also been studied, exercising at the goal of 30 minutes, 5 to 7 days per week, can decrease total cholesterol, increase HDL, decrease LDL, and for every 1 milligram increase in HDL or good cholesterol, the risk for CVD falls by 2 to 3%. So the best exercises are repetitive aerobic exercises that work multiple groups. So really it's important to find what the patients enjoy: walking, jogging, yoga, cycling, swimming, walking laps in the pool, whatever that looks like. And I always recommend that for people to start off slow, start off with 5 minutes a day and do that for a couple of weeks. And once that feels pretty good, to push up to 7 or 10 minutes a day for the next few weeks until they're at that goal of 30 minutes, at least 5 days a week. And as we discussed before, quitting smoking certainly improves the benefits of increasing HDL. And this leads us into the pharmacology portion of the presentation, which we'll pass things over to Kimber.
Okay, so I'll just start with an outline of the medication classes that we're going to review today, as well as there are some additional options listed here that are available, but we'll really skip over these today as these are mostly prescribed once the patient's been referred to specialty care. And then to start, I just wanted to provide this as a resource and a reference. It's from the 2020 ACE guidelines, and it does give a really good comprehensive overview of each of the medication classes. So it has the effects of lipids, different cardiovascular outcomes, as well as some pertinent side effects and drug interactions that we see with these medications. So we'll go ahead and start with statins, as these are going to be our first-line medications for most patients presenting with dyslipidemia or for use in primary prevention. Some pearls related to these medications Older statins had a shorter half-life and had to be dosed at bedtime. However, our newer statins do have longer half-lives and can actually be taken at any point throughout the day. And then I'm actually going to go through on separate slides related to statin intensities, managing intolerances, as well as drug interactions that we see with this class of medications. So listed here are the classifications of statins and the expected LDL reduction. So depending on what your treatment goals for the patient is, which we'll discuss more toward the end of this presentation, this can help guide you on which intensity you would want to use and if dual therapy might be necessary for your specific patient. And then you'll also notice on this list of statins, simvastatin 80 milligrams is no longer listed on here. And that's really because the initiation of simvastatin 80 or even the titration up to that dose is no longer recommended by the FDA because it did have a pretty hefty increased risk of myopathy, including rhabdomyolysis. For statin intolerances, I think this is something that we all have maybe seen in our practice, but more so patients are always aware of this potential side effect and tend to be nervous when starting statin therapy. So first, in good news, myopathy is fairly rare with this medication, and it's really only been reported to be around 2 to 5%. And true rhabdomyolysis occurs in a small amount of those cases. However, if this is something that you encounter or you want to talk through this with your patients, there are a lot of options. So first, it's always appropriate to trial an alternative statin. There are statins, and that would be pravastatin, rosuvastatin, and fluvastatin, and those are associated with a lower rate of myalgias. Additionally, you'll always see in the guidelines this frequently used phrase of placing patients on the maximally tolerated dose. So you can always decrease the dose to a lower intensity or utilize what we call pulse dosing. That's where we dose every other day or less frequently if your patient needs that. One thing to note is if you are prescribing pulse dosing, you'll want to utilize statins that have longer half-lives, and I've listed those there, such as rosuvastatin or atorvastatin. And then obviously, it's always important to have these conversations with your patients and stress the long-term benefits that we see with statin therapy, and also provide education that not all statins are the same, especially if they've had issues with statins in the past. Then lastly, if patients cannot tolerate statins or they continue not to meet lipid goals that you've set for the patients, and we'll talk about each of these therapies moving forward, but there are additional lipid lowering, and these specifically target LDL that you can look at in the future. For drug interactions with statins, this table is from the guidelines and does show some common drug interactions that you might see. One thing to note is that most of these can actually be used with what is defined as a risk mitigation strategy, and that can be using specific statins only with certain medications, using statins up to a certain dose, or especially with some of the anti-infective agents, holding statin therapy for short term while the patient's also taking that medication. And really these have to be looked at on a case-by-case basis because it is a variety depending on which statin interacts with which one of these medications. But one thing to note on this slide is gemfibrozil is contraindicated to use with any statin because it does have such an increased risk of myopathies and rhabdomyolysis compared to some of these other drug interactions you'll see. Next is the cholesterol absorption inhibitor, and that's ezetimibe. This medication can also be considered as add-on therapy to statin therapy in high-risk patients or patients that are having side effects or even patients that aren't meeting the lipid goals that we set for them. Ezetimibe does decrease LDL to a lesser degree than most statins. However, it is overall well tolerated and does have a pretty low incidence of hepatotoxicity and myopathy. PCSK9 inhibitors are a newer class of agents, and these can also be used as add-ons to statin therapy, and you'll see these do significantly reduce LDL compared to ezetimibe. You get a 40 to 60% reduction on average in LDL. So again, when you're considering what add-on therapy might be most appropriate for your patient, kind of weighing where your patient is at baseline to where you want them to be. Again, these agents are overall well tolerated. The most common reaction is injection site reaction, so these are injectable medications. And there is limited evidence available, but there is potential for cross-sensitivity between these two agents. So if a patient has some type of reaction to Repatha, it's not unlikely that they could have that same reaction to Praluent. Other pearls about this class of medications includes that there is a development of antibodies against the drug that have been seen in studies. However, in those patients that develop antibodies, there's an overall low rate of decreased efficacy of the medications. So that might not be necessarily clinically relevant, but in a very low percentage of patients, you could see decreased efficacy. And additionally, compared to ezetimibe, which is available generic now, these are brand name and are much more expensive and can often be cost prohibitive for our patients. And then Jackie referred to this a little bit ago in the presentation, but a subject that comes up pretty often with the utilization of PCSK9 inhibitors is what LDL is too low. So I wanted to just give a few studies that provided some context and some background to this question and kind of aimed at answering this. So one of the original studies, and that's the first one listed here, found that there was an increased incidence of type 2 diabetes, hepatobiliary disorders, and insomnia in patients that had an LDL less than 70 compared to those that were above 70. However, this study was from 2008, and there were a lot of limitations in the study, including that patients that had an LDL less than 70 also had a higher incidence of metabolic syndrome compared to the group above 70. And then when they looked at patients that had an LDL less than 50 and compared that to above 50 to 70, they actually found no difference in events. So then when the PCSK9 inhibitors came out, their studies, just to kind of give some context of what LDL looked like in those patient populations, with Praluent, the baseline LDL for patients entering the study was 90, and then the mean LDL after treatment was between 45 to 60. And you'll notice this is higher than the mean baseline that we saw with Repatha, and that's really because Praluent in the study did a dose decrease if the LDL was less than 25, and then they actually discontinued the medication if the patient had two LDL levels that were less than 15. And then with Repatha, they had the same baseline LDL at 90 for their patient population. However, the mean LDL after treatment for the patients in the treatment group was actually 30, and this is because they did not dose decrease or discontinue the medication for patients with low LDL, and actually 42% of patients had an LDL below 25, and there was a study looking at that group of patients afterwards, and they found no increased rate of adverse events after 1.5 years of having an LDL below 25. And then the last study I was going to mention related to this topic looked at simvastatin and ezetimibe, and while this didn't include the PCSK9 inhibitors, it was a longer-term study that looked at safety of patients having an LDL less than 50, and they actually found over 6 years those patients had no increased rate of adverse events compared to those that had an LDL greater than 70. However, they did find a lower rate of cardiovascular events. So there is still some controversy around this topic, but I think since the trials of the PCSK9 inhibitors, it's overall believed to be safe, but can always consider raising treatment goals or backing off of treatment if patients are experiencing some of these side effects or any issues with the medication. So one of the last LDL lowering agents that I'll discuss today is bempedoic acid. And again, this is a newer medication. It's overall well tolerated, but it does have some unique considerations that I wanted to point out. So it has been found to have an increased incidence of gout attacks in patients with existing gout, as well as tendon rupture, and it does have some blood count side effects, so you'll want to note to at least monitor that every so often in your patients that are on this medication. And it also does have more drug interactions than our PCSK9 inhibitors or ezetimibe, so it'll be something that you always want to check up against the patient's current therapies. And then just noting, against PCSK9 inhibitors, there is a lower rate of LDL lowering, so you'll see a LDL decrease around 20%. However, it also does come in combination with ezetimibe, where you would get closer to a 40% reduction. So again, just considering what your goals for the patient are and what their baseline LDL levels are at will kind of help you pick treatment between all these additional options. The next two agents I'll discuss primarily target triglycerides. So starting with our omega-3 fatty acids, In this class of medications, Vasipa or icosapent ethyl has really started to dominate this class because it is the only medication that we have found to have a cardiovascular risk reduction. So it's approved for use in those with established cardiovascular disease with a triglyceride level above 150, or those with a triglyceride level above 150 that have diabetes and additional risk factors for cardiovascular disease, as well as in patients with hypertriglyceridemia and their triglycerides are greater than 1,000. Some things that consider precautions to take with this medication is it can increase the risk of bleeding, especially in patients on anticoagulants. It shouldn't be used in patients with a known allergy to any type of fish. As far as atrial fibrillation, with all the omega-3 fatty acids, we have seen an increased rate of AFib events in patients with existing AFib, so that's something to consider. And then overall, the most reported side effects are really this dyspepsia and having a taste aversion to the medication, but also to some foods that the patient maybe didn't have those aversions to before. And then with fibric acid derivatives, these also target triglycerides. One thing to note is they do have the increased potential to raise LDL. So again, something to consider if you have patients that are already not at goal related to LDL. And really these agents have overall fallen out of favor, except for in patients with exceedingly high triglycerides. But some considerations include looking at renal function because these medications should be dose adjusted. And then patients do have pretty high incidence of gastrointestinal side effects that can lead to discontinuation related to these medications. And then I have two more agents on here, and they're really just here for completeness. They've fallen out of favor due to high rates of side effects and marginal efficacy. But related to niacin, this medication can lower triglycerides and could be considered if patients have failed fibric acid derivatives or omega-3 fatty acid therapy, and they still haven't achieved triglycerides. But again, this medication has a really high rate of a lot of different side effects that you can see listed here. So it's not really recommended by the guidelines, but might be a kind of a last resort option that you have for your patients that do require that. And then the last medication I have on here are the bile acid sequestrants. These medications can lower LDL, but again, do have a fairly high rate of side effects. And noting in the pearls here, it is complicated to have patients with already complex medication regimens taking this medication because it has a high risk of interacting with pretty much preventing the absorption of any oral medication. So that's something to always consider if you are thinking about this as add-on therapy for your patient. And then I wanted to wrap up with some treatment algorithms to kind of put where these drugs can fit into therapy. And there are many, many guidelines out there. Most condition-specific guidelines have a portion on lipid management. So obviously always refer to those for patient-specific management. However, I wanted to go over a few select guidelines and how these medications can fit into therapy for general patient populations. So on the next few slides, I'll go through the ACE risk categories, the AHA, ACC primary and secondary prevention algorithms, as well as the ACE hypertriglyceridemia algorithm. And then just some general principles that you'll notice in these, as well as condition-specific guidelines that you would look at lipid management portions for, is that statins are pretty much always going to be first line. So whether that's initiating a statin, optimizing the dose of a statin medication, that's typically our first step in treatment. And then you can always consider add-on therapy depending on mostly, this presentation will mostly focus on LDL and triglycerides. So if you're targeting to lower LDL, you can always consider the addition of ezetimibe, a PCSK9 inhibitor, or the ACL inhibitor that's now available, as well as for triglycerides, the addition of an omega-3 fatty acid or a fibric acid derivative. And then with this last point, as Jackie pointed out, always encouraging lifestyle modification as well as glycemic control, especially in our patients with diabetes. So I'll start with guidance on when to advance therapy in patients, and really this is going to be different in individuals' practices. So sometimes we may be aiming for a specific reduction with statin therapy, specifically in primary prevention, or we might be following these more stringent ACE risk stratification and treatment goals. But just always ensure that your patient has the plan's been communicated to them. They kind of have an idea of what their goals are, because if you do need additional or add-on therapy, they're going to be way more receptive to those add-on therapies if they're following along with the treatment plan with you. And so these specific guidelines stratify by risk level, so you can see the definition in the second column for these, as well as the treatment goals. And for this presentation, again, I'm focusing mostly on LDL and triglycerides. So the triglyceride target for most patients being less than 150, and then the LDL goals you can see become more aggressive as the patient's risk increases. So for low-risk patients with no additional risk factors, we're typically shooting for less than 130, all the way up to patients with extreme risk, and those would be patients with existing ASCVD or a history of premature ASCVD, and we might be shooting for LDL targets that are closer to or less than 55. And then for this algorithm, I'm sure most of you have seen this before, but this is our 2018 AHA-ACC guidelines, and it outlines our statin benefit groups. So for patients with an LDL above 190, we are typically going to initiate a high-intensity statin. For patients with diabetes and between the ages of 40 to 75, we typically are going to want to initiate a moderate intensity statin. However, these guidelines, as well as the updated ADA guidelines, do say to consider a high-intensity statin if a patient's ASCVD risk score is greater than 20%. And then for our patients that are 40 to 75 years old and their LDL is between 70 and 190, we again look at their individual ASCVD risk scores and have that discussion between risk and benefit with the patient to determine if statin therapy is going to be appropriate. From the same guidelines, our last benefit group are those that we're aiming for secondary prevention. These patients typically are always going to require a high-intensity statin with the goal to reduce by 50%. Or, like I said, we might be aiming for those more aggressive lipid targets that we discussed from the ACE guidelines. And the exception here are for patients that are over the age of 75. And this, again, is really a patient-specific consideration and balancing the patient's quality of life and really the full patient picture to determine if you are going to initiate or continue statin at the current dose. The last algorithm I wanted to cover, also from the ACE guidelines, and this outlines the treatment of hypertriglyceridemia. So similar to previous treatment principles, always address lifestyle initially. So you can see here a decrease in weight, calories, especially as that relates to sugar and alcohol intake, can have a large impact on triglycerides. And then, like I mentioned before, making sure that if our patients have diabetes, that their A1C is well controlled, because that also can have a large impact on triglycerides. And this also follows the principle of starting with statin therapy and then considering the addition of icosapent ethyl or Vascepa if patients remain above goal. So we'll end the presentation with our assessment questions. And so this first patient is GF, is a 53-year-old male with type 2 diabetes and hypertension. He was admitted subsequent to an INSTEMI and underwent PCI with a drug-eluting stent 6 months ago. What medications are an appropriate addition to his regimen at this time? And then labs and values are shown here, and his current medications. Anything not listed you can assume is within normal limits. So it looks like most people put A, so initiate rosuvastatin 40 milligrams, that's a high-intensity statin. I will say a couple of other people put D or E, and I think D could potentially be an appropriate recommendation for this patient. If you consider a 50% reduction, this patient's LDL could be expected to go from 140 to 70, and so this patient could fit into that category of extreme risk, so we might want to be targeting an LDL less than 55. So adding B, which is a PCSK9 inhibitor, could be completely appropriate. I will say with insurance coverage, these medications often do require a prior authorization, so it can be difficult to get those approved initially without a patient being on a statin for 3 to 6 months. And then as far as looking at the answer option E, which includes fenofibrate as an additional option, while that could be appropriate in the future, this patient does have some room to improve his A1C. You can see that's 8.9. As well as with statins, we can expect some reduction in triglycerides. So that might be something you want to try the statin first and then maybe consider the addition of a fenofibrate if that's needed in the future.
All right, well, we've got just a few minutes left and we do have a question in the chat box, so I want to make sure that we get that. And also, if anyone else has any questions that you'd like to submit, go ahead and send that in through the Q&A little icon at the bottom of your screen. But the question here is, are there any recommendations when we get the pop-up box or the kind of interaction alert for potential interaction with statins? In cardiology, we are notified often with diltiazem and amiodarone. So Kimber, that might be a question for you.
Yes, so those can interact with statins, and I'll be honest and say I don't know off the top of my head which statins would be most appropriate for those. I can definitely look that up, but using something like LexiComp that we have on our virtual medical library and typing in the statin you're considering with whatever the medication you're getting that alert about, whether it's one of those or one of the many other medications. And typically on there, they'll have a management section on there. They'll describe the drug interaction, what was seen, and then they'll have appropriate management. So most of the time that'll include what statins that interaction was not found with, or if there's certain like max doses of the specific statin that you can use with those medications.
Thank you so much. Any other questions that people want to submit? Is Lp(a) normally covered by insurance?
I've not had anybody tell me no.
Yes, it's on.
Yeah.
It is covered?
It should be covered by insurance.
Okay.
Typically, it's covered by insurance. I've not had anybody have an issue with it as long as you've got a reason for doing it.
Okay, great. While we give it just another minute for any questions, I just want to remind everybody you're going to get the link into an evaluation for credit for this, in addition to an email. When you exit this webinar, you're going to see a link to SurveyMonkey. Just select the continue button for the evaluation and credit for the CME. I do want to invite everybody to join us for our next and final session in the pharmacology series live stream, which is going to be on Wednesday, September 28th at 12 noon. This is going to be a session that's going to focus on safe prescribing of controlled substances. We have Elizabeth Archer-Nanda, who is one of our advanced practice providers with the Office of Advanced Practice, is going to be helping leading that, as well as her pharmacy partner. This is going to be, again, on September the 28th at noon. We do have one last question that's come in here. I'll read here quickly. It says, recently had a patient with a fasting lipid panel that was not able to be processed because it was so high. So a referral was placed to the lipid center, but received notification the patient needed cardiology evaluation first. What is typically recommended in this scenario? So Jackie or Amy, do you want to kind of talk through how that referral process works to the lipid center?
Yeah, that it typically.
I mean, what probably happened was when they actually ran the serum, it was so thick with fat on top. You have the bottom of the tube with your blood, and then probably an inch and a half of actually like just clear fat there. So I would say most likely the initial thing that you would want to do if you want to do something before you get them to cardiology would be to put them on a statin if you're able to, because you know it's going to hit things. But then definitely if you see that much there, they need a cardiology referral because they're probably high risk for a lot of things.
So should people be entering, instead of an ambulatory referral to the lipid center, should they just be placing a referral to cardiology?
At this
Yes.
point, it needs to go through cardiology.
Okay.
It'd be nice to open it out to everybody, but right now it has to go through cardiology first.
Okay, all right, great. Thank you for that clarification. All right, well, we are right at time here. So again, thank you so much to everybody for your time. Thank you for our speakers for your knowledge and expertise. This has been tremendously helpful, I know, for myself, as well as I'm sure everybody else here. I hope you guys have a great rest of your day and have a great week. Bye-bye.